When it comes to medical practice, we know that every patient is unique and presents their own challenges. These are patients who are calm or easy to work with, highly anxious, non-compliant or have trouble seeking help, and more volatile or difficult. These behaviors impact the doctor-patient relationship and health outcomes, regardless of the physician's expertise. What if we tell you that understanding one concept can give you a framework to prepare for these behaviors and thus foster a better patient-doctor relationship? That concept is attachment theory. No one doubts that effective medical care depends not only on medical expertise, but also on the quality of the doctor-patient relationship. Attunement to the attachment aspects of relationships, as well as attention to mentalizing, is as applicable to general medical practice as it is to psychiatry. Please check out part 1 of this video, which will be linked in the description box below, to learn more about this topic in depth. The different attachment styles are dismissive-avoidant, fearful-avoidant, anxious-preoccupied, which are all categorized as insecure attachment. And finally, we have the secure attachment style. Insecure attachment styles impact a patient's behavior in a medical setting, and can adversely affect their health outcomes regardless of the expertise of the physician. Studies have shown that having an insecure attachment style can lead to increased morbidity and mortality. If we can identify patients based on their attachment style and combine it with an understanding of some of their self-sabotaging behaviors, physicians can tailor their approach to the patient and prevent some of these adverse health outcomes. Patients' attachment styles can be identified through a self-reported questionnaire, such as the relationship questionnaire developed by Bartholomew and Horowitz. This assessment describes the characteristics of the different styles. Respondents indicate on a 7-point scale to which extent each description applies to their feelings and behavior in close relations, such as relationships with peers. Let's take a look at the 4 styles and how their attachment translates to behaviors in a medical setting. Secure. These individuals have a positive view of themselves and others, and report greater satisfaction in their relationships. This attachment results from caregivers who are emotionally available and respond to the child's emotional needs. In medical practice, secure patients take trust in their doctors, are compliant with the treatments offered, have healthy coping strategies when faced with medical adversities, and take more benefit from holistic approaches in patient care. Anxious preoccupied. These patients have a negative view of themselves and a positive view of others. This results from caregivers who fail to be consistently emotionally available. In medical practice, this translates to patients who seek constant reassurance from their physician, but have the innate belief that they will not recover from their illness. Their anxiety is partly relieved through contact with their doctor, but it does not resolve it. As a result, these patients have significantly more health visits and reported significantly more physical symptoms. These are individuals who will present high levels of emotional expressiveness during consultations, emotional dysregulation, worry, and impulsiveness in decisions, which in turn affects their health. Studies suggest that anxious patients have an increased risk of morbidity and mortality. They have higher levels of cortisol and lower levels of cellular immune indicators. If these patients experience long durations of stress and anxiety, their cortisol levels decrease drastically, and this can suppress their immune system by up to 70%. This increases their susceptibility to infectious diseases and impairs the ability to fight off illness. Therefore, the needs of these patients must be met by doctors to avoid extreme negative outcomes. Dismissive-avoidant. Patients with dismissive-avoidant attachment styles are found to underreport their symptoms and will not seek medical help at early stages of illness. When they do seek medical attention, they will need to feel in full control of the process. They may not elaborate on their problems, symptoms, illness, or the effect of their illness because of reluctance to elicit support from others. Along with this, they may typically display non-compliance with the treatment. Studies show that diabetes patients with dismissive attachment styles will have higher mortality rates, as they resist the need to seek help and will maintain lower levels of exercise, diet control, and medication adherence. Patients with this style are also associated with higher rates of smoking. Smoking, like overeating and drinking, may be thought of as a way of coping with upsetting emotions without depending on other people. And since these patients typically visit their doctors less, They lack the recurring advice and support for quitting smoking that has been shown to be related to successful cessation. Fearful-Avoidant. These are individuals who have fluctuating views of themselves and others, and are uncomfortable with the idea of getting close to others or having to depend on others. They have their own emotions and have fluctuating levels of emotional expression. Medically, these individuals may present with a mixture of features of the anxious, preoccupied, and dismissive avoidant patients that we've just discussed. Through understanding these styles, physicians may be able to better respond to the unique interpersonal characteristics of insecure patients. Let's look at how to tailor the approach to treating the insecure styles. For an anxious, preoccupied patient, the first step is to recognize the anxiety. Anxiety can manifest differently depending on the patient and the situation. It can present as anger, sarcasm, worry, or withdrawal. Listening is the next important step, as it enables the anxious patient to feel respected and builds trust and confidence in the care. Offer empathy. Anxiety should not be dismissed or minimized, and instead should be validated. Finally, help the patient relax through suggesting relaxation techniques to manage their stress and anxiety, not simply the illness at hand. Avoidant. As mentioned, avoidant patients may be non-adherent to a treatment plan prescribed by their physician. To manage this, it is important to communicate clearly and frankly with the patient about why the treatment plan or lifestyle change is important, and how best to implement a recommended course of action. Avoidant patients typically respond to logic, thus showing evidence of the importance of adherence may help. It is also important to offer positive reinforcement when the patient does display secure behaviors, such as opening up about symptoms or their feelings, or adhering to the treatment plan. For the fearful-avoidant patient, we can expect to see behaviors that range from avoidant to anxious. This includes not being willing to share information and symptoms to being excessively worried. Thus, follow the steps recommended for both the avoidant and anxious patients when such behaviors arise in the fearful-avoidant patient. Through our understanding of attachment theory, it is clear that it can serve as a very useful tool in medical practice, but how can this be implemented? Patients can perhaps take an attachment assessment at the general practitioner's office in order to determine their attachment style. This information can then be shared between any other physician or specialist that the patient may interact with. Finally, while attachment theory can be a useful tool to understand patients, it does not predict all behaviors. Despite this classification, it's important to understand that everyone is different and to treat every patient differently.